doesn't come back. So this is basically the histological underpinning of these late potentials. This is the same process, really, that happens in ARVD. Marty showed these beautiful epsilon waves in ARVD, and here's the same thing. So in ARVD, you also get programmed cell death, apoptosis with separation of myocardial fibers and tracts, and manifestations of these separated and delayed activated tracts are the epsilon waves. So it's very similar to the ischemic cardiomyopathy. Back to our surgeon, who's now in the cath lab, we've shown we can induce this tachycardia. So the way we do it, and it tends to be a low stress thing, certainly less stressful in doing the mapping and ablation than it is doing pulmonary vein isolation, at least I find. And what do we look for? So we're pacing here, and what we're looking for is on very high gain. Here's our ablation signals here, looking for these little guys here, the late potentials. You can see some of them can be as late as 384 milliseconds past the stimulus mark. And I think these are potentially part of a reentrant circuit of ventricular tachycardia. So this is the kind of thing we knew from the morphology where to focus on, and the fact that they had an old inferior infarct. This is the kind of reconstruction. We get a posterior view of the left ventricle. These are all the scarred areas. Here's the electrograms. We also do pacing from sites where we did record these electrograms. You get this huge latency. You see a pacing spike and a huge delay before emergence of the surface electrogram, suggesting you're sitting on a tract within the scar that has the ability to conduct out into the surrounding normal myocardium. And so we tag these areas that are points of interest. We'll look at the morphology to see if there's any similarity to the tachycardia. Here, there's a whole selected number of areas. And then we go ahead and sort of ablate those and just take them out of the equation completely. Here's a third sort of presentation that we talked about, the sort of very slow ventricular tachycardia that we see more and more often now in people who are on amiodarone beta blockers and defibrillators. So this is the kind of thing, but very symptomatic. So this is a 71-year-old man, had an infarct at the age of 41, sort of an old inferior infarct, refractory recurrent ventricular tachycardia at 105 per minute, frequent ATPs, recurrent shocks. Logs of his defibrillator show here an example, sort of see barely above 600 milliseconds, the VT cycle. Here's the atria, burst spacing, ramp, nothing really works fine, it gets a shock. And this happened just over and over again. Here's his logs in 2005, the number of therapies, and then after ablation, nothing. And here's the kind of thing, because his ventricular tachycardia was so slow, we actually mapped him during VT. This is a voltage map, and then you'll see next should be an activation map through the left ventricle. So this is the slow area, anterior view of the left ventricle during VT. And you can see there'll be slow conduction coming back through this posterior scarred area, breaking out there, coming around, and then zigzagging through here to break out again the next beat. So ablations in this area of the return path sort of ended up in a good outcome. So what about VT therapy and outcomes? So increasingly this focus, and I think that somebody raised a question this morning about at what point should you consider doing VT ablation in patients that have a defibrillator after 1 shock, 2 shocks or more. So in the first instance, Vivek Reddy sort of has a New England Journal publication showing that certainly ablations can, over a period of some months up to 2 years, reduce the number of therapies from the defibrillator. And the other important thing, increasingly, I guess, from the SCUDF and other evidence, is that shocks, the number of shocks, and even inappropriate shocks basically increase the risk of death. So you can see out here that gradually, the more shocks you have, there is evidence now building up a case that this leads to an increased mortality. So this makes a more and more compelling case, perhaps, to intervene earlier. So our shocks are associated with increased mortality, quite apart from the fact that the quality of life is diminished in these people. So as I said, our approach is to do the substrate, and in contrast, a lot of people think there's kind of a terror of doing a VT ablation, because a lot of them are actually done during VT, people with already impaired left ventricular function. And of course, when you induce VT, these are very tedious mapping procedures that take a long time. So There's a high likelihood of patients ending up in shock during the end of the procedure. If, by contrast, you really do the approaches during ventricular pacing, it's a very relaxed procedure that you can sort of take lots of time to identify potentially areas of interest and then take them out of the equation. And when you're done, you go back in and again repeat an induction to see what you have, whether you removed it. And with that kind of approach, these are our kind of results, that we have 75% success acutely after one procedure. And the encouraging thing is, of the ones that are refractory, if you go back in for a second time, about half of those people will become responders, and the ones that you still have to go even for a third time, you can recruit some of those, at least convert them to be responders. Just switch gears a little bit to the epicardial approach. Marty already sort of addressed nice details and various criteria for things that might suggest a VT has the critical substrate at the epicardial surface, in particular the slow upstroke of the QRS and time to reach the peak. Access to the pericardium we talked about a little bit earlier. I think it's, again, when you do 2 or 3 cases, everything goes very well. You might tend to be a bit blasé, but I think people who've done a large volume sort of do encounter fairly significant problems. We did have one case that the right ventricle free wall was lacerated, so a 1 centimeter tear that had to go to the R, fixed up. Luckily, it wasn't a big issue, but just wouldn't stop. I know other colleagues have had sort of laceration of branches of the coronary arteries that then require being addressed. But it's certainly something that increasingly we do. And I just want to share this other case. This is a little bit like the giant cell myocarditis, but wasn't. A young woman had dilated cardiomyopathy, also coincidentally, but I don't think of any great relevance, non-compaction of the left ventricle, recurrent VT, went on to have the EPS. Here we are with shooting the coronaries, which is important before you're ablating. Here's the catheter in the pericardial space. And this is just another projection showing the same thing, well away from any major coronaries. And this is the tachycardia morphology, suggesting it's coming from the inferior portion. And here's a reconstruction of the activation in the mesh mode. You can see it was epicardial. This is the inferior surface. You can see from the icon, figure 8, in contrast to the one that we mentioned before on the inferior surface. But what was of interest is this. So here we are in ventricular tachycardia. We're mapping with our ablation catheter. Cycle length of the VT, 412 milliseconds in the critical. But look at this. On the proximal electrode, very strikingly, there's the VT, the predominant one, manifest. And within it, there's another electrograms marching through dissociated at 320 milliseconds. So in fact, what this was 2 VTs linked together with a concealed VT intermittently resetting the manifest VT. And when we came on burning in that region, first we switched off the concealed VT and then the manifest ventricular tachycardia. So this was the kind of a picture of the figure 8 on the inferior surface and the concealed VT. Unfortunately, with these roving electrodes, not possible to really map the all we could do is mark the extent of those potentials of the concealed VT, but not anything itself. I think I'll stop at this point and just thank you again for allowing me to share this information with you. Thank you.